So we're talking about peripheral neuropathy today. It's a common side effect of myeloma treatment. Sensory, motor and autonomic neuropathies are commonly reported distressing and disabling symptoms of treatments like thalidomide and bortezomib. Bortezomib, as you know, is also known as Velcade. So the majority of you sitting in this room will have had one of these drugs or are going to experience one of them or both of them through your treatment phase with myeloma. Although the presentation of the symptoms and the way that we intervene can differ, more and more patients every year are being exposed to the drugs because of the order that we give them in to each patient. So the exact prevalence or the amount of patients that have neuropathy while they're treated with myeloma we don't know, because they present quite differently depending on their history, the drugs they're taking and the types of treatments they receive and continue to receive. Okay, so the National Cancer Institute describes peripheral neuropathy as a nerve problem that causes pain, numbness, tingling, swelling or muscle weakness to different parts of the body. It usually begins in the hands and feet and it gets worse over time. Also associated with peripheral neuropathy is a syndrome called autonomic neuropathy. It's very common as well, particularly for patients that are on Velcade, and it involves damage to the nerves that carry information from the brain and the spinal cord to the organs that we don't think about how they work. So our heart and our blood pressure, blood vessels, glands, sweat glands, all those things that happen that we aren't really aware of. That's an autonomic neuropathy. So in myeloma, typically the symptoms of neuropathy are related to the affected nerves. In myeloma we tend to see sensory, motor and autonomic neuropathy. But before we go into it, probably just have a little biology lesson. So our nervous system, that's our body, they're all the different nerves that are in our body, and it works a bit like a highway. So messages are sent and received through the nervous system, they go to the brain, it perceives what's going on in the body and around it. There's millions of nerve cells that are picking up these impulses and sending them around our body. So an outside or an inside stimuli are identified by the peripheral nerve, and that translates through an impulse through the nervous system up to the brain. The brain decodes that and sends a message down. So an example of that would be if you put your hand on a hot plate, you don't leave it there. You automatically pull it off, and that's because the peripheral nerves picked it up, travelled up to your brain said, oh hell, that's hot, get your hand off that. So it's an automatic reaction that happens through our nervous system. So if any component of that nervous system is damaged, it can cause irreversible harm. So with neuropathy, we're not really sure what the mechanism is that causes it. This is what a nerve essentially looks like, but we believe that the neurotoxicities result from damage to the dorsal root ganglia and the peripheral nerve axon. So those bits there get damaged, and if you damage part of the nerve, it's no longer able to function, do the thing that it was made to do. And initially the symptoms are from small fibres. So the characteristics of small fibre damage would be that prickling or tingling sensation that you can feel, and that progresses to the larger fibre and you get deficits that are like pain, uncomfortable sensations when people touch you, deficits in the way you perceive pain, so you sometimes can't identify that pain is there. And the identification of pain, like in the example of heat, protects you from damage. So if you've lost that ability to actually perceive something's painful, walking on glass, you'll keep doing it. So there's those long-term effects that occur when you damage those different nerves. The other thing that also changes with that is the way you perceive temperature. And that can be quite a difficult thing for patients, particularly our elderly patients, because as an older person, your temperature gauge doesn't work as effectively as well. Your immune systems, when you've got myeloma, are decreased as well. So you're opening yourself up to other things. So you wouldn't think peripheral neuropathy has that widespread effect, but it actually does. So as that neuropathy progresses, it can become irreversible, and we won't be able to get you back to that former ability to perceive temperature, pain, all the things that I've just talked about. So with myeloma, it's multifactorial. So when you're talking about peripheral neuropathy in myeloma, it's caused by different things. It's not just from the drugs. I will concentrate on what the drugs do to you, but you need to understand that about 20% of patients on diagnosis present with peripheral neuropathy. So that's actually caused by the protein building up in the tissues, whether it's the hands, the feet, whatever. Plasmacytomas, so a plasmacytoma is a collection of myeloma cells, so it's like a single example of myeloma, and it's not necessarily in the bone marrow. So some of you would have been diagnosed with the plasmacytoma as opposed to myeloma. Plasmacytomas particularly can cause nerve and cord compression, but as you all are aware, so can myeloma. If you've got a lytic lesion, or what we all like to call a hole in the bone, they can also cause compression of nerves. That can cause you that feeling of tingling and numbness in your hands. Some of our patients, some of you here may have sort of a double diagnosis where you've got amyloid and myeloma, and amyloid deposits cause neuropathy as well, and the lytic lesions or the bony holes. So that's your presenting problem, is the myeloma. On top of that, some of you are of older age, some of you aren't. Unfortunately in myeloma, if you're over 65, you're old, apparently, as you all know, because that means you're transplant not eligible. So we are a bit definitive in how we define old age in myeloma. Diabetes, so a lot of people that have diabetes have existing neuropathy. People that drink a lot of alcohol, past history or present history of shingles, renal disease, vitamin B deficiency. A lot of the inflammatory and autoimmune diseases have a lot of neuropathy as well, and collectively they're called pre-existing neuropathy. So you've come in with a problem before we even get to you with our drugs. Finally, treatment-related neuropathy, and that's previous exposure to a neurotoxic agent or that you're actually having one. So today we're actually going to talk about chemo-induced neuropathy, so the neuropathy that occurs from the actual medications. It's quite common in other drugs as well. It's not just because of myeloma that we're talking about this, and it's very well researched and very well documented in other malignancies, not so much for us, but as thalidomide and Velcade have become the first-line treatments, we see more and more of it. And that longevity of the symptoms, and then on top of that adding an additional drug that has the same risk factors, makes it pretty much something that most patients that have myeloma that receive treatment are going to experience. So thalidomide, when you've had prolonged exposure to thalidomide, it'll induce mild to moderate symptoms, and they appear to be cumulative. So the longer you stay on the drug, the more likely that you're going to have these symptoms. Initially, it will be painful sensory changes, such as that numbness and the tingling in your fingers, and then the toes and the feet. And it tends to spread proximally up the limb. So we call it a stocking glove configuration. So patients will often start by saying they've got tingly fingers, and then it will progress into their hand and up their arm, or tingly toes in their foot. So it's like a stocking or a glove. That's the sensory type of change, the tingling, and then it moves on to more of a motor things where you actually have trouble manipulating things. So small buttons, zips, you have weakness in your limbs. And as that progresses, so if we don't intervene and do something about it, or you don't tell us about it, more and more symptoms will start to progress. And things like loss of vibration and joint position sense, that's your ability to know that if you close your eyes, your arm's above your head. You can all do it, but if you've got neuropathy and it gets progressive, you'll start to lose all of those innate things that your nervous system controls. The vibration, the sense of vibration is the test the doctors, when they hit that tuning fork and stick it on the back of your head, that's just another way of picking up the sensitivity of nerves that patients have and whether they've been damaged or not. As you can imagine, as you start to lose these senses, you also start to lose your balance. You become what's called ataxic, which means you start to walk kind of weird and your gait is disturbed, and that puts you at a much higher risk for a fall. And you all know, holes in bones, crumbly bones. That's what everyone says to you about your skeleton, is you've got crumbly bones, you need to be careful of a fall. So we really need to look at the whole picture. The neuropathy isn't just something you're feeling, it's something that can really cause you a lot of other effects as well. In thalidomide, there is some autonomic neuropathy, but not so much as in Velcade. And the autonomic neuropathy that we see in thalidomide, and anyone that's had it would be very familiar with it, is constipation. That's an example of autonomic neuropathy. And for some of you, you may have experienced bradycardia, which is slowed heart rate, and the doctors have to actually take you off the drug because of that particular side effect. They can reduce the drug, they can temporarily discontinue it, they can give you a bit of a drug holiday if your myeloma is quite stable. There's all kinds of ways of dealing with that. So, for example, MPT is one of the typical drugs that we give, a combination of melphalan, prednisone and thalidomide, and that's a 12-month type of treatment. Sometimes around 6 months, and if a patient is starting to show symptoms, they might be able to look at your blood readings and everything else about your myeloma and either reduce the thalidomide or start to take you off it altogether. For those of you who've had transplant, so if you've had a transplant, particularly probably 12 months or more ago, thalidomide maintenance was a very common thing to have after your transplant, and that usually only goes for 12 months as well. With myeloma, even though we're not quite into individualised treatment yet, I feel fairly confident in saying that haematologists are very good at looking at an individual patient and hearing and seeing what their problems are and then adapting their treatment, so to speak, to keep you on the drug. The goal of the treatment, and particularly when we start to talk about Velcade, is to keep you on it. Because the longer we can keep you on it, as much as it's not great for you guys, you're going to get a better response if you've been on the treatment for a longer period of time. But I'll talk about that a bit more. So bortezomib, which is the other name, is quite different to thalidomide in the way that it presents. So it's typically known to give neuropathic pain. So we'll give Velcade and patients will experience some tingling and some numbness in their fingers and their toes, and the doctors will keep going very slowly to see that they can still give that drug. So lenalidomide is I guess the easiest way to say is like a cousin of thalidomide. It's an immunomodulating drug, so it's not a chemotherapy, so to speak, but it's a myeloma chemotherapy. It has some neuropathy, but it's not the most associated. Sorry, that's not the way I'm supposed to say it. So thalidomide and Velcade are definitely drugs that cause neuropathy. There is a small percentage of patients who have lenalidomide after time can get some neuropathy as well. All right, so that's just a bit like what's happening to some people. They feel like their foot's in a jam, they've got tacks in their feet, someone's squeezing their toes with spanners, or their feet are on fire. So this is just a little example of some of the things that my patients have said to me. Derek, you might have said one of these things. Numbness, tingling, I'm unsteady on my feet, my legs feel like jelly, I'm weak, I'm clumsy, I've got a loss of depth perception, which isn't good when you're trying to walk down steps or drive a car. Can't stand the sheets touching me in bed. So very oversensitive feeling with regards to your skin. Burning, stinging, I'm walking on hot coals, I feel like ants are biting me. You can all read. I'm wearing gloves and socks all the time. I can't tell if the water's hot or cold. And then as it gets worse, I've got shooting electric pains up my legs. I feel like there's sandpaper under my feet all the time. So they're very descriptive, and it's really important that you feel comfortable telling the doctors these things, because they actually give them a much clearer picture of what you're experiencing than if you just say, yeah, I got tingling in my fingers. Well, tingling in my fingers, but I can't stand the sheets touching me, or I can't walk because of that, is a much more descriptive way of telling the doctor where you're at. So that's a bit like what people feel like, that there's ants just biting their feet constantly, and it doesn't stop for some patients. It's there all the time. Okay, so what are we going to do about this? So to get effective assessment of your neuropathy, we need good communication, because it's very subjective, as you can see. So as doctors and as nurses, we need to know those symptoms and the characteristics and the intensity of those characteristics. So if there's a loss of feeling, if your limbs feel heavy, if there's pain, and if that pain is localised, which means it's in one place, or it's diffused, which means it's going up your leg and into your hip, etc. Where the pain started and where it is now, and then how those symptoms interfere with your physical, emotional and role functioning. So if symptoms are affecting your day-to-day life, you can't get dressed, you can't do your shoelaces up, you can't do your buttons up, that's interfering with your quality of life as well. And we don't aim to give you treatment for myeloma to ruin your quality of life. We're actually trying to get some of it back by taking care of the disease and the issues that it brings. So things that are really important to you, like needlework and playing an instrument. I've had quite a few patients recently who are musicians, and we've been very careful at watching them, because some of them, that's their life, but it's also their way of making money, it's their career. So if you can no longer play the guitar or teach the guitar because we gave you a drug that we didn't monitor properly, we've more than ruined your life in many ways. We've taken away your ability to earn money as well. So really important to alert the doctors before the treatment. If you're a thalidomide patient and you're at home and you don't come and see us once every 6 weeks, what the PA thalidomide patients do, so that's a fairly long time. If your symptoms are getting worse, call in and tell someone. If you don't have a me kind of person, a myeloma nurse, then call in to the doctor's secretary and say, can you tell Dr. So-and-so that my neuropathy is getting worse? It may not need a visit to the hospital, it may just mean that they can decrease your dose or give it to you every other day, things like that. Okay, but it's important that you're feeling that you can tell the doctors what's going on as well. So we use different tools to assess and communicate between one doctor and nurse. It's that important. It's that important that from one dose to the next that we can find out what's going on. And for some of the patients who, in my situation, didn't quite understand at the beginning of their cycles why I was so involved, because I was trying to educate them and keep a weekly check on them. I think after time they realised I wasn't really trying to interfere with their lives or take away their independence, or because I'd be ringing them going, hello, it's Carmel from the PA. Now, how's those fingers and toes? And I think when you don't have your neuropathy, it's a bit of an invasion of privacy, and it's a bit of an invasion of your independence. But hopefully by the end of today you can see a method in my madness. Robert, particularly. I used to drive him mad calling him with my de-identified telephone number, which doesn't help at all because everyone's thinking that I'm a cold caller of telemarketing. Okay, so using a tool helps. It helps us to keep an eye from one cycle to the next what patients are doing. But as patients, you need to be able to articulate that experience and discover and find out ways to help you manage the symptoms. Those symptoms that I've been talking about that can lead to irreversible damage they can actually go on to ruin relationships with families, they can cause you anxiety, they can cause a lot of fear, they can cause you depression, because if you're not able to do the things you love to do or you need to do, that all has a psychological and emotional impact on you as well. So prevention is the key, and reporting the symptoms early doesn't mean your treatment's going to stop. It's really important. There's lots of papers written about people that tell white lies. So you ask a patient, do you have any tingling or numbness in your fingers or toes? Nope. Do you have any trouble walking? Nope. No problems, nothing. They don't tell you, so we don't adjust the dose. So eventually you can see it. They can't. You can see them walk into clinic and they're like that, or they're having trouble working out where the steps are, or they're dizzy and lightheaded and they've come in with a fall and a fractured hip. So it's not worth it. It's really important that you are upfront and honest about it. If your doctors dismiss you as being, you know, a little bit like the squeaky wheel, doesn't matter. It's important that you're able to convey that information to them so that we can protect you from the long-term damage that these drugs can do. Really important, with all of that said, these drugs are there to help you and they're there to treat your disease. We just need to keep a little bit of a tight rein on them and the effect that they have on your life. So they're fantastic for treating your myeloma. They can still treat your myeloma as long as we're looking at the side effects as well. And I came across peripheral neuropathy by accident. I actually went and asked about using one of these tools in the clinic, and like anything in Queensland Health, you can't just use a piece of paper. It's got to go through a million pieces of ethical consideration, and someone else has to approve it and what have you. And I took it to the wrong person and said, can I use this? And they went, oh, let's do a research study on that. So I was immediately roped into it, and I've probably become a bit obsessive about it. So I might be a little bit over the peripheral neuropathy thing, but it's important. And for any of you that is actually sitting there and has it, I think you know where I'm coming from in regards to looking after your safety and minimising the harm that's going on. So what can you guys do for yourself? Sounds really basic, some of these things, and I don't mean to talk down to anyone, but they're things we don't think of. So you need to identify the hazards in your own home. If you can't feel something, a loose mat, or notice that there's an electrical cord because your foot just doesn't touch it, you'll fall over it. So it's identifying those sort of things that are around your house that could cause you to fall. Making sure you're avoiding extremes of temperatures, keeping your hands and your feet warm. Even when it's summer, people feel like their hands are cold. Keep them warm. It will help your neuropathy. Check that temperature in your shower, because if you've got no feeling in your feet and you whack your hand or your foot in there and it's scalding hot, you'll burn yourself. So just, that doesn't contain to the water in your sink where you wash up. That's got to be hot water. It's got to be able to kill germs when you're cleaning food. So in that case, you need to be wearing gloves. You're not wearing gloves in the shower. That would be really weird. You need to wear gloves when you're washing up. Check your feet, particularly for areas of pressure or rubbing. Avoid tight-fitting shoes or clothes, and always wear shoes when you go outside, because if you don't have that ability to pick up that you've stood on something, you're going to end up with a cut, which is an infection, which is a temperature of 38 degrees, which is a triple O ambulance call to the emergency in a week or two in hospital. So it's really important to do those everyday things. Focus on what you're doing. Now, I can't focus on one thing at the same time. I have to do about 20 things, but it is important, if you're watching the Channel 10 news and chopping the onions, but you can't feel it, that you are not chopping your hand. So you do actually need to focus on what you're doing so that you're not causing yourself any more problems. If you're having problems just with day-to-day things, ask for a referral to an OT or a PT. So occupational therapists have great gadgets that help us with things that we have difficulty with. So, you know, if you've lost a bit of power in the hand, they've got jar openers, and they've got things that pick up. They've got really good gadgets. Sometimes it's just worth a good chat to an OT because they've got some fascinating material. And the physio, particularly if you've got any bony involvement and your gait's already affected or you've had a fall, we need to make sure that you're safely mobilising around. It may only be for a period of time that you might need an assistive device, but if that keeps you safe and from breaking a bone or having a fall, that's important. Okay, so what are we going to do about it? With respect to the medical management, we need to look after the symptoms, so talk to the patients, find out what's going on, manage the comorbidities. So they're things that I spoke about earlier: vitamin B deficiencies, diabetes, any of the other inflammatory or those type of immune disorders, that we need to address those as well as the myeloma. We need to carefully monitor you and modify that dose, the scheduling and the method of administration if necessary. We need to monitor your blood pressure prior to your Velcade. So PA people, you know that I'm always banging on about people, make sure the nurses in daycare take your blood pressure before you get Velcade. It's really important because the drop in your blood pressure can show up before the other symptoms show up sometimes. So it's almost a little bit of a way of working out what's going on before it actually happens. So you'll all have different ways that your drug's given in your clinics. In our clinic, after about cycle 1, if the patient is stable, they're responding, and I'm floating around keeping an eye on them and talking to them, the doctors will often not review the patients except for on day 1 of their cycle. So if you're on a 5-week cycle, the doctor might only see you at the beginning of that cycle. So you may get 4 more doses of Velcade. So it's really important that if you're lightheaded or dizzy and you're going to daycare presenting without a doctor review, you get the nurses to take your blood pressure before they give it to you. I did a swing by about 3 weeks ago in our clinic and stopped 3 doses of Velcade from that alone. But all it did was stop the dose, patient drank lots of fluid, we reduced the dose, no more problems. They've continued on their therapy. So just be aware of it. It's a way of you helping to manage your own treatment. I am obviously talking very much from a PA experience, and I need you all to understand that anything I say here, you need to actually talk to your own doctors about, because different facilities have different ways of doing things. Sometimes if you're not sure how to approach a doctor about it, you can just blame that girl at the Leukaemia Foundation who was talking about how I should have my blood pressure monitored. Is that something we do here? You don't question them, you just ask them as though you've got no idea. That's how I do it as well. So if I need to question a doctor, I pretend I don't know what I'm talking about and let them tell me what. Is Dr. Henson here yet? No. So let them tell me, so it's new information. And finally, really importantly, is managing this neuropathic pain. So we use a fairly multimodal approach to manage neuropathic pain. So a lot of you want to know what to do for yourselves as opposed to what the doctors are going to do for you. There's a lot of papers that have been written about neuropathy and non-drug treatment and how patients can utilise different things. So one of the things out there is called capsaicin cream. I have to say that there is no studies on myeloma, particularly in neuropathic pain. It's all about every other drug given in a chemotherapy regime. And most of the studies are done on breast cancer, ovarian cancer, lymphoma, because they've got much bigger cohorts and those drugs have been around for a lot longer. So these are things that get used for patients that are having other drugs that cause neuropathy. But capsaicin cream, they believe, acts on heat receptors, so it gives patients some relief. Some emollients like cocoa butter. Dr. Millay said, show me a male patient of mine who will put cocoa butter on because I want to meet him. And I said, well, Dr. Millay, you obviously have not been reading the papers because a lot of patients get quite a bit of relief from this. So you can just buy it at the chemist. They don't know what the mechanism is. It may be just the massage. It may be the touch. We don't know, but it doesn't matter if it gives you some relief. Menthol, he believes that his male patients would be putting menthol on their feet rather than cocoa butter because it acts on cold receptors. Now, there are papers that talk about topical lidocaine, so that's like a topical anaesthetic, but that's usually used for patients that have had shingles. So if any of you have had shingles, you know how horribly painful that can be, and it lasts for a long time. So for some patients, they do get some relief from that. Once again, disclaimer, go back and ask your doctors if you're allowed to do this. It's not something I'm recommending you can do. It's something that there's been studies done on and patients have had some success with them. Other things, I think I use alternatives, not the word I meant to use there because it often means Freaky Friday things you can do, so other ideas. would be massage. So give or take, if you've got some crumbly bones, that massage needs to be gentle and it needs to be something the doctors are happy for you to have, but there is nothing wrong with anybody massaging your hands or feet. It's a lovely thing to do. It generally makes people feel good anyway, and even if it takes your mind off it for 5 minutes, then it's effective. Reflexology, I don't quite know how that works, but there are papers out there on it. Same for acupuncture. So there's been patients that have tried acupuncture, they've found some relief from it. Once again, talk to your doctors, see if it's okay with them. Low resistant bed clothing, that just means things that aren't too heavy. So, you know, the old days where we had 10 blankets, possibly a doona might be something that's a little bit easier and not so heavy on your skin. Silk sheets, they're nice and soft and they don't cause friction, so it sounds weird, but we had a patient donate silk sheets. We took it into our transplant patient on the ward and she just couldn't believe how great she felt, because she just didn't feel that prickly tinglingness of the cotton sheets. They didn't last very long once the laundry got hold of them, but they were worth a go. Using gloves and socks, sometimes using like the flight socks and the flight gloves, they're compression sort of socks that help to give relief. Now, Dana-Farber is a cancer institute in the United States. They have a thing called the neuropathy protocol. It involves lots of vitamins and some different alpha-lipoic acid. We don't use it at PA routinely, but if patients come and ask the doctors, they will always consider it and find out what else they're on in conjunction that might be helpful or not to them. So they're things that you can ask about. Just generally muscle cramps that aren't muscle cramps from neuropathy, often they need to just have a look at your magnesium and potassium levels. Some people give tonic water and it helps a little bit, so they're just little extra things you can do. Unfortunately, there is very little evidence to say that anything really works, but different patients, when I suggest things to them, will come back and it might work for a time, and then they come back and go, oh, that was useless. What else have you got up your sleeve? And we'll try something else. So they're all worth a little bit of a try and see if they work. From our point of view, medically, we would use a multi-drug approach when we're dealing with neuropathic pain. So patients may be on opiates, they may be on anticonvulsants like I'm not even going to try to say that word, gabapentin and pregabalin, which you might know as Lyrica. Just pre-warning about Lyrica, if you're on Lyrica for pain for some other reason, try and still key into your neuropathy, because it works so well sometimes that it masks the neuropathy. So just be aware of when you're on Lyrica to institute some of those safety guidelines with respect to heat and cold temperature. Antidepressants often work. It's not that we're putting you on an antidepressant because you're depressed. It's because the side effects of these particular drugs, and there's been quite a lot of studies, particularly on this one, that's the latest one they've studied, with other neuropathic chemo agents, that patients get relief because they act on nerve sensors. So, finally, prevention is the key. You need to speak up. You need to report your symptoms. You need to ask questions. No question is silly. No reporting of a symptom is stupid. It's something that will prevent you from having additional problems. Thank you, everybody.